I'm Dr. Tewin, Associate Professor from Myanmar. Now coming over to Malaysia, already 15 years as the lecturer. First of all, 8 years in University of Malaysia, Sarawak. I worked there for 8 years. After that, shifted here. Now it's my 7th year in University Kuala Lumpur, right? College of Medicine, Perak, Ipoh, Perak, and Malaysia. I really enjoy working here today. Here, please shoot. We have altogether cameraman Shafiq and other 7 students. So 8 of them, they are my final year MBBS students. They are one of the top students of the class. So today I arranged to show them how we do breast examination. Okay, first of all, I would like to tell you all how to approach a patient. Approach of a patient, you better assume the patient as your own relative so that you won't make mistakes. After that, be with the chaperone. And when you approach, friendly manner, smiley face so that they will be very happy with you. Okay, once you are in the ward, first of all, observe privacy, cover up the screen, be with the chaperone again, and adequate and appropriate exposure. With that, patient will be very happy with you. And another 6 steps that you do need to do either in the ward or when you are going for exam with OSCE, Objective Structured Clinical Exam. There, first of all, although we keep mannequin as the sample to examine, so you are going to see the simulated patient first of all. With that, the way you approach, there are 6 steps. Number 1, introduce yourself, what you are. And next, ask the name of the patient, their age, their education, their job, married, children, so to get the rapport. Number 3, explanation, what you are going to do. You are going to do breast examination, explain to them. And after that, get the verbal consent. Okay, will you please allow me to do that? Okay, they will say yes, go ahead. So next one, okay, this breast examination, there may be a little bit discomfort, but don't worry, I'll be very gentle and I'll be doing very quickly. So after this, once we finish everything, I'm going to thank you. These are the 6 steps. No? Now I'm going to show you, come. Regarding breast examination, now we are going to examine mannequin. But through case, if you are going to examine a live patient, you can keep different positions. Sitting position, standing position, showing axilla with the hands behind the head and asking her to bend forward. By that time you compare the level of the nipples and any contraction or pulling effect by the cancer or not. After that, you can still ask the patient to keep on the buttock. By that time you can palpate to exclude attachment to the deeper structures or muscles. These are different positions. Done already. Now I'm going to show you. Come. Okay, here, first of all, inspection. Come nearer. Inspection. Now I'm going to inspect both sides. Although the patient may be complaining about the lump, they will show you, okay, upper inner quadrant of the right breast. But still, you have to exclude other breasts as well. This case have got abnormality both sides. Never mind, I'm not going to pay attention to the other breast. Assuming that once we are going to examine both breasts, normal breast first. After that, come to the abnormal breast. Okay? Now for that, now inspection. First of all, you inspect and tell any positive signs. Here, the skin of the breast, now what we see are border range. And as well as border range effect around the areola, as well as cracked nipple, maybe slightly blood discharge. As patient already informed us that she has a lump here. So apart from that, we have to exclude any other possible positive findings like erythema, eczema, dilated veins, visible lump, puckering, dimpling, and so on. Okay, exclude that already. So now I'm going to do palpation. Now, Being here, we have to start from away from the complaint side, not to leave behind any part. So we have three methods. One method is circular method. So we are palpating circularly the whole breast. Another method is split method. That means medial half, lateral half. That is called split method. Another method is wedge method. We are going to examine all the wedge sections. Okay, with this method application, now I am going to palpate. Here is the lump. So for the lump, we need to know size, shape, surface, consistency, mobility, fixity, and any other abnormality and so on. Okay, site, regarding the location, now I can feel here the swelling is about 3 centimeters diameter, rounded, hard nodular, little bit irregular, and 3 centimeters away from the nipple. And this lump lying at the 2 o'clock, to 3 o'clock position. That means we do need to correlate with o'clock position and away from the nipple. So site already done. Size already. Shape rounded, irregular. Surface not attached to the skin, deeper, fixed little bit. So in true case, we have to ask to press on the buttock by the time to move. So that will show up fixity. Irregularity is there. Okay, size, shape, surface, mobility, fixity. Okay, anything else? Okay, that's all for the time being. Now, what are the signs that you could elicit that we have to think no other than cancer? If the patient gives the history of growing in size very fast within short period, that is one. Another one is when you examine the lump is big enough already, very hard already, fixed already, and there are other changes like bordering, puckering, dimpling, retracted nipple, and then blood discharge, okay, as well as axillary lymph nodes enlargement, or multiple secondaries, liver, lung, bone, brain. These are all pointing towards the malignant. Even if the patient's breast lump already ulcerated, there are signs for the ulcer to assume as cancer. So what are those? The ulcer may be raised edge, irregular margin, eroded, dirty surface, bleeds on touch. These are the typical signs to diagnose as malignant ulcer. As well as the discharge will be very smelly. Okay? So tumor, T, and we have the classification, T and M classification. I don't need to go into detail about this yet. Okay, after this examination, please come, Hadi. So he's going to be my model patient now to show how, after the examination of the breast lump, now I'm going to show how I'm going to examine the right side axillary lymph nodes. There are 5 groups, okay? Being right side, I'm going to use my right hand. Afterwards, I'm going to palpate anterior group or pectoral group, central group, posterior group or subscapular group, and deep inside apical group, and around the arm, lateral group. These are all 5 lymph nodes. Depending on if the lymph nodes is palpable and mobile, they are T1. Palpable, fixed, T2 already. If advanced to other groups already, T3. Okay, here, after these 5 groups, now I'm going to palpate. You can palpate to your deltoid group, in between the deltoid bone, the deltoid muscle, and then the pectoral muscle, deltoid group. That is called deltoid lymph nodes, or being under the clavicle, we call it subscapular. Another one step is the suprascapular. Okay, shrug the shoulder. Okay, by now I am going to palpate both the supraclavicular. For the left side, we call it Barchop's lymph nodes. If there is positive for cancer stomach, we call it Tricia sign, and deep transverse cervical lymph nodes. This is for lateral quadrant. For the medial, they will go to the internal mammary chain or internal thoracic chain. Those we can't feel, we can't see. But with CT scan or MRI, we can do so. But here, for the lower quadrant, they will go subcranial lymph node group. From there, transalomic, transperitoneal, they will spread to the ovary cruciate tumor only in the reproductive age patient. So that's all. Okay, done. Thank you very much. So after that now, I'm going to exclude all the, okay, Hadi, please come, sit down here. Liver, lung, bone, brain, all the 4 metastatic sites. First of all, I will palpate for the liver enlargement, presence of ascites with the percussion and the shaping dullness, and then if the patient is a female, I will palpate for the ovarian enlargement to exclude cruciate tumor. So after that, lung. For the lung, stand up. Of course, female patient, no? Mostly common. So for the lungs, I have to examine percussion, stony dullness, the spreads already there, pleural effusion. Or if any part of the lungs being blocked by space occupying lesion or cannonball. So once that lungs collapse already, there are changes. You will know with your stethoscope and so on. So that is for the lungs. Okay, sit down. For the bones, there are 7 steps. That's me very, very quick. Vertebral bodies, thoracic cage, pelvic bones, 2 humerus, 2 femur, and scalp. 6 steps. These are the ones you better exclude. Are there any pain, any swelling, or pathological fracture? That's all. You exclude bony secondaries. Okay, regarding that, I would like to share a little bit about what are the common tumors that can spread to bones. There are 5 origins, mostly are 1, that's mean thyroid, 2, that's mean breast, 1, that's mean bronchus or cancer lung, or 2 mean kidneys, 1 mean prostate. These 5, they will spread usually to the bone. But the uniqueness is prostate and breast, these are the 2. Once they spread, mostly all 5 of them, they spread with osteolytic bone destruction. But prostate and breast can make osteoblastic as well, bone formation. That's why when you look at the X-ray, you can see more dense and white changes. But still they are weak, so they can give rise to bony swelling, pain, and pathological fracture. Okay? So after this, now, bone already. So last one is the brain. For the brain, most of the time is very late already. That's why you have to ask from the very beginning the story. The story means, okay, what are those? Increasing any space occupying lesion inside the brain that may give rise to the symptoms like headache, nausea, vomiting, any weaknesses of any 4 limbs, and then seizures, convulsions, and loss of consciousness. These are all CNS changes. So you have to explore during your history taking. That's how we examine the breast. Okay? Thank you very much. Stop.